So much, sir. So we'll move on to Dr. Pravin Krishna's talk. His talk is going to be an enigma. We are not sure what he's going to talk about.
Thanks, Shreyas, and thanks to Gitanshi as well, who set up this talk. The ask was to speak about using epithelial maps in refractive surgery and in planning surgery as well. Unfortunately, I don't think we use epithelial maps a lot in planning and executing surgeries at this point of time, and that's why I thought we'll probably talk about something that's a little alternative. So I'm going to be speaking about an alternative for keratoconus. So very quickly, when you speak about the nomogram for handling keratoconus, I'm going to be focusing on severe keratoconus, which are not amenable to do cross-linking. And typically, you start to think about doing a keratoplasty in these patients, and what do you do for these patients as an alternative? So because of the fact that we started to have a title that links to epithelial thickness, I guess the link is the fact that epithelial thickness is known to be lower in the area of the cone, and that's one of the diagnostic measures for diagnosing keratoconus in very early cases as well. So this is the typical case that I'm talking about, somebody who has unaided vision of counting fingers at 1 meter, spectacles 2200, does well with contact lenses but is unwilling to wear them or is probably uncomfortable with them, and also very steep topography, very steep keratometry, and a very thin cornea, 350 microns thereabouts. So there have been alternatives that have been described. One is a Bowman's membrane transplant by the group from Rotterdam that seems to have achieved some amount of flattening and reduction of progression in these patients. There also have been groups from the US who've spoken about Bowman's membrane transplant as well for a marginal improvement in the best spectacle corrected visual acuity. From Spain, there has been stromal lenticular implantation with decellularized stromal lenticules, human corneas, with again marginal improvement in the K values as well as marginal improvement in the visual acuity of these patients. I think the most common use, at least that we've seen in India, has been the implantation of allolenticules from patients who are undergoing SMILE. This again has been proven in rabbits to be something that is viable, and I think we've seen several case series as well as case reports saying that this is a potential technique to increase corneal stromal thickness so that you can cross-link these patients. But it is interesting to see that there are reports of immunological stromal rejection even in these patients if you do not decellularize these corneas. So one of the thought processes that we had then was to try and use a non-cellular implant inside the cornea to see if we can stabilize the cornea. And this comes with work on corneal inlays, which potentially started about 14 years ago. This is an inlay that actually was for refractive correction, and this was an abandoned project because the inlay tended to accumulate a lot of deposits. So we started working with this precision engineering company in Germany, and they have a machine that actually makes our dissect lenticules in our eye bank. And following that, we also started work with them to see if we can use the same kind of technique to correct myopia like a PRK, but not using a laser with only a blade. We had partial success in this measure as well, but this led to also trying to create these kind of lenticules in donor corneas from the eye bank and implant them under a LASIK flap. This is called LIKE, and this is to correct high hyperopia again. So this method seemed to have some success, but again in very high hyperopia. An example of this procedure is in this patient who had +8 correction of hyperopia and did really well with a residual of about 1 +1 diopters and very, very stable over a period of 4 years. That's the lenticle inside. So we tried to apply this idea to a patient who had very severe keratoconus. You can see that the K readings in the range of about 70. This patient had vision of CF 1 meter, refraction of -11, -325, correcting to 2200. He did well with contact lenses, but again, he was intolerant. If you look at the corneal thickness, just below 500 microns was his corneal thickness again. So this is when, along with this company, the porcine collagen lenticule that they had invented was something that we wanted to test out. And this is basically porcine collagen lenticule that is decellularized and is completely devoid of any antigenic stimulus. This is again not novel in humans. They have been used, porcine collagen has been used for cardiac valves, several other areas as well. and most recently xenotransplantation of porcine collagen cornea as well in the case of fungal keratitis. So for this particular patient, we decided that we're going to try and use this lenticule inside the cornea. And again, just looking back at the epithelial thickness, you see that the epithelium is thin over the area of the cone, and you can see this is quite a steep ectatic cornea preoperatively. So the procedure is quite simple. The procedure, this is called Xenia as of now. It is available officially in some test sites, and it includes creating a small corneal pocket within the cornea. This needs to be controlled because these are already very thin corneas and the epithelial thickness can be variable. And this implant, which again can be customized from the thickness as well as from the diameter, can be injected into the stromal pocket. The stromal pocket, again, we tried creating it using the Visumax, but it seems as if the femtosecond laser by Alcon, the FS200, gave us a more robust and deeper stromal pocket, and it was more easy to implant it in those eyes. So once you put the lenticule inside, this is pre-op pictures, this is 1 month post-op, and this is 8 months post-op. You see it's actually quite clear of the same patient that I showed you preoperatively, and is also quite stable. The pupil is dilated because we also do a fundus evaluation at the time of the patient's visit. On the OCT, you can see that there is significant flattening of the cornea as well from preoperative to postoperative 8 months. And this is again evidenced by the preoperative versus postoperative corneal topography. And you'll see in the center that we've achieved about close to 33 diopters of flattening in the center, which I think is not possible with any other surgical technique at this point of time. So this patient also had very stable topography at 1 month, which seemed to maintain itself, and similar kind of cylinder at the end of 8 months of follow-up, which was last month. Again, interesting because to link epithelial thickness, we found that the epithelial thickness as well had increased compared to the preoperative thin epithelium, had actually become hypertrophic midway at about 3 months, and then at about 8 months seems to have become quite regularized. And you see that the corneal thickness has become about 70 microns thicker, which is the thickness of the lenticule we implanted. Visual acuity, he went from 2200 best corrected to 2060 best corrected, from a -11 to a -0.5 myope. The cylinder is thereabouts in the same range, so really not much change in the cylindrical correction. So this again is a very controlled study. This is approved by the CDSCO only for 5 patients right now, and we have waiting for 1 year follow-up. We have about 8 months of follow-up for these patients. And if you look at the patients uniformly at the 3-month visit, all of them seem to have done well with a significant reduction in the refraction and quite a significant improvement in the visual acuity as well. So this, in summary, is a stromal lenticule implantation to actually fill the gap for patients who are not suitable for cross-linking or any other procedure where vision might not improve, who can't use contact lenses, and the only option is to do a keratoplasty. And it seems to be a simple 10-minute procedure that can be done under topical anesthesia, can be done at the laser, just requires the same skills as you require in laser surgery or SMILE, and actually gives the patient very rapid visual recovery as well. So we hope that this is something that will become part of the algorithm to manage keratoconus in the future. Thank you.
Very interesting, sir. And while I request Rupal Shah madam to kindly set up a laptop. So for any of these tissue additive procedures, apart from volume replacement to also cause the kind of fantastic flattening that you showed, you would have to have them a little thicker in the periphery and thinner in the center. So does Xenia?
Not required. The reason why this seems to work is this is a pre-cross-linked lenticule, and this is also a shaped lenticule. It is not cut according to any curvature. You can actually preset the curvature of the lenticule and ensure it's cross-linked. So it actually is rigid. So once it goes in, it tends to maintain its shape. So even on the OCT, it still was thicker in the center and thinner on the periphery as well. It's the change in the shape because of the rigid cross-linked lenticule that makes the cornea flatter in the center.
Can you do a topo guided after this?
Oh, sure you can. You can do a topo guided on the lenticule before you put it in as well.
Yeah, you should actually do a customization there.
Yeah.
So you can wait for some time and see, and then you can do a topo guided to reduce the spectacle dependence.
Yeah, but since this is part of a clinical trial where that is not part of the protocol, we're just hoping that we complete 1 year without any issues. And once that is done, maybe in the future, the options are limitless.
No, because without that, the volume replacement will definitely cause some flattening, sir. That's
True.
because of the addition of the tissue itself. But like a topo-guided regularization, reducing the tissue, because if we have a thicker periphery, we are likely to have more flattening the center was what, I mean, that's what we've been taught through our different implants, intracorneal rings and other things, where we create a more mid-peripheral steepening to have a flatter center. Do you think that would be possible in these implants? Or?
I think the mechanics of that is a little different from this one, because there you only have stretching of the periphery and nothing in the center. This is actually something in the center that is physically compressing or flattening the cornea. So I think the mechanics are a little different.
Epikeratophobia, but more modernized, I suppose.
Well, intrastomal epikeratophobia.
Depends on what depth you put the lenticle at.
It seems as if, again, for the first 3 cases, we used a relatively shallow depth, about 120, like we would do with SMILE. But then we found that the epithelium was not very healthy in those patients. So we went deeper. In the next 2 patients, we were about 150 microns. That seemed to work much better.
And that will possibly be better.
I'm just thinking, I was thinking if it's possible for us, even for those of us who don't have an access to this, can we cross-link a SMILE lenticule and put it inside? Would it work the same way as this?
I think the difference is the fact that, one, this is decellularized. So you will not have any stromal infiltration in this lenticule. In fact, when we looked at confocal 8 months later, there are no cells in it even right now. Second is because you can cross-link a tissue that is outside the human eye as strongly, as many times as you want. So this is actually very rigid. It's a custom cross-linking protocol. Whereas our regular cross-linking, I don't think is going to transfer the amount of rigidity that this kind of lenticule will have.
So you don't think it can be done with a human
I think it
cornea?
can. I think it can, but I think it's also about supply and demand. I think human corneas, though we have plenty of tissues that potentially can be used, that are not used for keratoplasty, I think eventually it's not going to be a viable market to have that, because we will still be dependent on human tissues. The processing of them is going to destroy quite a few. So I think this porcine lenticule probably is more of a viable implant.
Yeah, is it keratoconus?
Or it is just standard? Is it customized?
It can be customized. It can be customized based on, it can be also, because this is again cut with a very precision microkeratome, the one that I showed you in the beginning called a nanotome. Depending on the cavity that you actually generate, you can also do a topo-guided lenticule generation as well. So there are limitless possibilities for this in the future.
Thank you so much, sir.
There is a future for a non-organic, meaning, so not a living tissue, but an artificial tissue to do the same thing?
I don't think so, because this again comes from, in 2004 was the inlays that I first showed you. And I think we've had several companies try to put these non-living tissue inside the human cornea. Nobody really has had success, especially with anything that is more than 4 millimeters in diameter. I think Raindrop as well as the camera were the only ones that were successful, but because they had a hole and because they were smaller. Thank you.
Thank you so much, sir. Very interesting talk, and